Merci. Si vous me permettez, je vais donner ma conférence en anglais. Sinon, je risque de manquer les éléments importants de ce que j'aimerais vous dire. So I'll give my talk in English just so I can make sure that I speak clearly, or as clearly as I can, in probably the language I master the best. I want to thank you, obviously, the Institut Jérôme Lejeune and the Fondation Jérôme Lejeune for this conference. I'll be talking to you about more standardization and scale development. Hopefully, you're not totally saturated. But I want to talk about adaptive behavior. Before I start, I want to acknowledge my co-authors on the Diagnostic Adaptive Behavior Scale and the funding sources we had to do this work. It's really an exciting time for adaptive behavior and the assessment of adaptive behavior. I want to talk today about the diagnostic criteria. We're actually now, many of you may realize this, we're actually now in actually a convergence of what is adaptive behavior and how we should assess it and how it's part of our diagnostic criteria for intellectual disability. We're actually in a very exciting time, and I know in France you have a lot of opportunities to increase your use of adaptive behavior when making a diagnosis of intellectual disability, and I hope this presentation and this tool will be something that you'll find interesting. So I want to focus on the diagnostic criteria for intellectual disability, which are fairly universal when you look at them, and as well as the importance and the role of adaptive behavior. And then I want to finish on presenting a tool that we just finished developing after a number of years of hard work, and hopefully it won't take me 8 years to explain to you what we did. So the American Association on Intellectual and Developmental Disabilities, and maybe I should have a disclaimer here that I'm a past president of AAIDD and a co-author of this terminology and classification manual. But AIDD's current definition is quite clear and defines intellectual disability, what we used to call mental retardation, as being characterized by significant limitations in both intellectual functioning and adaptive behavior. And we define adaptive behavior as being part of 3 domains or 3 skill areas: conceptual adaptive skills, social adaptive skills, and practical adaptive skills. And I see some of you writing, I'm happy to make my slides available. I can give them to Sylvia Sacco, and certainly we can upload them on the website of the conference. So if you need to take notes, please do. But I'm happy to send you my slides or make them available on the website of the Institute. The DSM-5, where there's a lot of controversy around many things, and fortunately at the 11th hour, the DSM-5 came through with a definition that seems to be identical to the AAIDD definition. And there's a little bit of confusion because in the DSM-5 they use intellectual disability, parentheses, intellectual developmental disorder. And the parentheses was used by the American Psychiatric Association to align with the World Health Organization's work on the ICD-11, the International Classification of Diseases, 11th edition, which will come out probably in 2016. However, you'll see in a minute, the World Health Organization has abandoned intellectual developmental disorder. So DSM 5.1 will probably make that change by striking that parentheses. But the DSM 5 defines intellectual disability as being composed of 3 factors as well. So you need to assess and document 3 things, just like AIDD: significant deficits in intellectual functioning, and significant deficits in adaptive behavior as defined by conceptual, social, and practical domains. And the third one being age of onset of these deficits during the developmental period. All right, so now we have perfect alignment. The International Classification of Diseases, which is used extensively in Europe. In the US, we use it mostly for coding and insurance purposes. And in the US, we're still on the ICD-9. We're barely able to get to 10. We keep pushing it back. One day we'll get to ICD-10, and then ICD-11 will probably have been out for a decade. I'm being cynical. But nonetheless, this is the definition that's used around the world. And In current work, this seems to be the final definition that the World Health Organization will go to field trials with. And they call it disorders of intellectual development, but essentially it's intellectual disability or disorders of ID. And it's significant deficits in both. So you'll see all these are identical. Both intellectual and adaptive behavior, including conceptual, social, and practical, and originates during the developmental period. So again, I think we're in a very exciting time where we have worldwide convergence of how we define what we used to call mental retardation and now call intellectual disability. So this feels like, in English we use a French expression, déjà vu, and it's like déjà vu all over again, and this is a famous American philosopher who was also a baseball player, Yogi Berra, who said it's like déjà vu all over again. And that's because back in 1959, the AIDD in the 5th edition of their definition, in 1959, that's like more than 50 years ago, defined mental retardation as being associated with significant deficits in intellectual functioning and significant deficits in maturation, which are practical skills, learning, which are conceptual skills, and social adjustment, which are social skills. So where the DSM, AIDD, and the World Health Organization are is not entirely new. It's sort of like, do you have that movie in France, Back to the Future? But that's sort of how it feels. So we've come, and in 61, the AIDD further refined that definition of maturation, learning, and social adjustment as being what they called adaptive behavior, and that's the first time we saw the term adaptive behavior used, which was in 1961. And I want to point out that this is really true. So these three aspects of adaptive behavior are of different importance as qualifying conditions of intellectual disability at different ages. And really, that's true today too, right? We expect different things as a society from a 4-year-old than we do from a 20-year-old. And if a 4-year-old does what other 4-year-olds do, they don't have deficits in adaptive behavior. But if a 20-year-old does what a 4-year-old does, but doesn't do what a 20-year-old does, they do have significant deficits of adaptive behavior. So relevance of adaptive behavior is really important not only for intellectual disability, but a lot of other neurological disorders. We're talking about autism, ADHD, emotional disorders we heard about yesterday, hearing and motor impairments, communication disorders, learning disabilities. And this is the one that we use, not the one the UK uses, which is intellectual disability, but all learning disabilities. As well as adaptive behavior is often an outcome measure that we measure in aging and age-related decline. Alzheimer, as we heard Drs. Lott and Silverman talk about, adaptive behavior is often what we track. And changes in adaptive behavior or activities of daily living are very important in our assessment and our research and understanding of these conditions. So we have this perfect synergy, convergence around how we diagnose and understand and conceptualize adaptive behavior. So let me tell you what is conceptual skills, just so we all are on the same page. And we heard Dr. Abidudu talk about language yesterday. It includes language, includes functional academics, reading, writing, arithmetic, self-direction, money management, and time concepts. That's what we mean by conceptual skills. Social skills are really these interpersonal skills, responsibility, self-esteem, wariness, naivete, what Steve Greenspan publishes a lot on around the issue of gullibility, which in our research has shown is a salient feature of intellectual disability in adults, older adolescents and adults, but less so in children, because all children are gullible, even those who are typically developing. So it's hard for us to distinguish gullibility at a younger age, but certainly becomes an important feature in adolescence and adulthood. Following rules, etiquette, social problem solving, and so forth. And the third area is practical skills, which relate to activities of daily living, self-care, domestic skills, work, safety, healthcare, and travel. That's what we mean by practical skills. Another paradigm shift in the DSM-5 around intellectual disability, and hold on, stay seated, don't fall out, is they've totally abandoned IQ as the driver for the levels of severity. So again, an opportunity for many of you in France to use less of the IQ test and use more of the adaptive behavior assessment. So they've abandoned mild ID, moderate ID, severe ID, profound ID. Not entirely, they still have it. But it's no longer determined on the person's intellectual functioning, but rather it's determined on the assessment of the person's adaptive behavior. And that's because, as the DSM-5 correctly points out, adaptive behavior is really what drives our support needs, not entirely, but largely. We all know here that two people who have an IQ of 65 and may have a diagnosis of mild intellectual disability may have a very different clinical profile, may have very different support needs, depending on their health issues, their behavior problems, their motivation, their mental health problems, etc. So now mild ID, moderate ID, severe ID, profound ID will be driven, according to the DSM, by the assessment of adaptive behavior. And I know my colleague, Dr. Ravel, will be happy to know that both AAIDD and DSM place a lot of importance on clinical judgment. So we're not taking standardized tests and scores and robotically applying them to yes or no, the person has a diagnosis. But you must use clinical judgment to interpret those results. And there are some people who may have IQs above 70 who still, based on our clinical judgment, meet the definition of intellectual disability, and we just have to justify that. Conversely, there may be people who have adaptive behavior deficits, but don't meet our clinical judgment for a diagnosis of intellectual disability, and that is permissible. So clinical judgment is an important component in the diagnostic process. Now, Bob Sherlock and Ruth Lucassen published a really good book on clinical judgment, and I encourage you to read it. And what they say is clinical judgment is not a professional eyeballing it or winging it or writing on a prescription pad. The person has an intellectual disability according to my clinical judgment. It's not that. And clinical judgment is rooted in training, experience, knowledge, and interpretation of valid assessment results. It's all of that. So the way we assess significant deficits is really through standardized assessment. There are many good standardized assessments that are available. What we're looking at generally are people who have significant deficits, so the old bell curve, which is still tried and true. So we're looking at people who are kind of in this green zone, roughly, in their functioning when we're making a diagnosis, because we're looking at people who are significantly below average, the general population average, not other people with intellectual disability, the general population. So when you look at all the adaptive behavior scales out there, there are about more than 200, but there are really 4 good scales available right now. And there's been a lot of work around these 4 adaptive behavior scales. And I know Vincent Desportes will be talking about his work on the translation of the Vineland 2. There's been a lot of work around that. I know the ABIS has been translated in different languages. And so the question is why are we developing another adaptive behavior scale, right? When we have these 4 very good instruments that are available. And the reason we decided to develop these 4, a new adaptive behavior scale is that these instruments were not developed based on the conceptual, social, and practical adaptive skill model. These all predate that conceptual understanding of adaptive behavior. All these instruments were developed for 2 purposes. 1, to help with the diagnostic information, but also 2, to help with planning and intervention. So they're very long and robust and have a lot of instruments to try and capture things like what Henry Leland would talk about in terms of like zones of proximal development and areas of intervention and so forth. So we wanted to develop an instrument that was exclusively or primarily focused on diagnostic, around the cutoff. So not assessing people who are in the average range, but people who are focused and what are the skills that really determine significant deficits. So in the population that we work with, what are those items that, depending on the person's age, whether they're 4, 8, 10, 15, 21, what are the items that discriminate between someone who has significant deficits and someone who doesn't? We wanted to use a procedure that was based on a semi-structured interview that was tailored and developed according to conceptual, social, and practical, and didn't have maladaptive behaviors, because maladaptive behaviors are a totally different construct to adaptive behavior. And that is an unfortunate misnomer, because problem behavior could be driven in part, sometimes, by problems of adaptive behavior, but often are driven by problems of health, mental health, environment, and so forth, and have nothing to do with the person's adaptive functioning or adaptive skills. We wanted to include items of these higher order social skills, such as gullibility and avoiding victimization. And my colleague, Dr. Verdugo, talked a lot about classical test theory. We wanted to use item response theory for our scale development and our scoring. And I'll talk a little bit about that, but not too much. As I see, I have to pick up the tempo. So I'm not going to belabor you. Trust me, this was a long process. We started off with 2,000 items, and you're happy that we don't have 2,000 items today because nobody would use it, although it would be comprehensive. Nobody would use it. We then whittled that down through Q-sort process, group refinement, using expert panels. We whittled it down eventually to 260 items. 260 item scale was the instrument that we then used to field test and do our standardization, and then to do further analysis using item response theory. So the DABS, or the Diagnostic Adaptive Behavior Scale, is a semi-structured interview between a professional and a person who knows the individual well. We do not recommend, for diagnostic purposes, self-respondent. And that is because we know that a lot of people who have intellectual disability of any etiologic origin have a tendency to perhaps exaggerate what they can do and can't do, like many of us, and have a tendency of doing cloak of competence or masking. So generally, for diagnostic purposes, we refer to multiple respondents. And I'll talk a little bit about the rating in a minute. So the interviewer is a professional, could be a social worker, could be a teacher, could be a psychologist. The respondent generally is a family member, a parent, a grandparent, could be a coworker, could be a teacher, could be anyone who knows the person well. So we develop and standardize the test based on US norms. We started off with 4 age version, 1 protocol for 4 to 8-year-olds, 1 for 9 to 15-year-olds, and 1 for 16 to 21-year-olds. And we started our standardization in 2009. Our complete sample is about 1,058 people, and it was developed in the US, and it's basically standardized and normed on a sample of general population individuals that are representative of the US, and these are US Census indicators of how your population should be distributed geographically. We had 50-50 men, women, and we had 46 of 50 US states involved in our sampling. So the assessed persons, and you'll see we oversampled in people with intellectual disability. And the reason we wanted to do that is because we wanted to look at sensitivity specificity. And I'll show you sensitivity specificity in a minute. So this is sort of the co-occurring conditions. Again, this is predominantly a general population group of 4 to 21-year-olds on which we normed and developed the parameters of the scale. These are the respondents generally. Most of them were women. Some were men, 14% were men, 70% were mothers, 10% were fathers, some were siblings, grandparents, aunts, uncles, caregivers, teachers, and others. Those were the respondents. In terms of the interviewers, we had about 174 interviewers doing all these interviews. So we had a large pool of interviewers. Many of them were psychologists. Many of them were graduate students. Some of them were social workers, teachers, administrators, and so forth. This is sort of what the scale looks like. This is the final version. Again, so the final version is 75 items, 25 for each of the subdomains. And it's normed and standardized for individuals from 4 to 21. And these are some sample items. So social, and you can see these are of a varying difficulty level or age. So ask for help when needed, says hello, shows emotions and feelings appropriately, recognizes when his or her rights are being violated. That may be good for CRPD. Recognizes signs that someone is trying to exploit him or her, talks with others when it does not interfere with work. So you can see these are different levels of social skills. Practical skills: adjust the water temperature of the faucet, uses restroom, follows a daily schedule, maintains steady work pace, takes medication as directed, makes purchases relative to his or her budget or means. Many of us have trouble with that. And then conceptual skills. So there's some academic achievement. Reads at least 10 words, states day, month, and year of birth, manages money management, makes a list for shopping, grocery, things to buy, sets a clock or watch to correct time. So those are the 3 domains. I'm going to try and pick up the pace here. So we use item response theory, which is a little bit different than classical test theory, and what it's based on the premise is that an item is difficult for everybody at the same level. We just have to figure out what that item difficulty is. It doesn't matter your ability level. That item is as hard to its own properties. Obviously, the more skill you have, the more likely you will succeed the item. So we looked at item difficulty and item discrimination. Those were the 2 parameters we focused on in scale development using IRT model. And we use a graded response model because the way we assess adaptive behavior is not binary. It's not 0, 1, but it's 0, cannot do, to can do perfectly. And in between we have median scores of yes, can do somewhat, or yes, can do, but not perfectly well, but a little bit better. And this is sort of the grading that we have for the DABs, which looks a lot like the rating scale of many instruments. So no ability, yes, does with reminders, 2 does sometimes independently, so a little bit more proficient, and 3 is totally proficient, does all the time without reminders independently. And then we have a no score. The beauty of using item response theory is that when we use IRT for scoring, the no score, the skip, is actually skipped. It's not scored as a 0 like the ABIS or the Vineland might do, so it's actually treated as missing information. Of course, the more we have skips and the more we have no scores, the more error we have around the score we obtain, and that is just related to how much information we get. All right, so this is sort of what the results would look like. Standardized scores are based on a mean of 100, standard deviation of 15. There's no law requiring us to do that, but that's general practice in standardized tests. And we provide a standard score on conceptual, social, and practical. And you see the standard error measurement is really dependent on what items are responded to. If all 75 items are answered, the SEM will be at its lowest because all the information is maximal. So how good is the DABS, and I'm almost finished, how good is the DABS at identifying people who have a diagnosis? And we heard Wayne Silverman talk yesterday a little bit about sensitivity, specificity. So we wanted to look at sensitivity. Out of a sample of 1,000 people, we had roughly 900 that had no intellectual disability, and we had a large number who had an intellectual disability, and wanted to see if we could discriminate based on the DABS who had mental retardation from those who didn't. So sensitivity is a measure of how good are we at identifying those who do have an intellectual disability. Specificity is how good are we at excluding those who don't have an intellectual disability based on their results on the DABS. So this is sort of what we had. We had a sample of 388 in the 4 to 8 years old, and we come up with a sensitivity of about 81%. So 81% of those who have intellectual disability also had significant deficits on one of those 3 adaptive behavior domains on the DABs. And if you look at specificity, we have even better specificity. It's about 91%. And we did the same with the other 3 age groups. So the 9 to 15-year-olds, the 16 to 21-year-olds. And we get a sensitivity that ranges from 81 to 98% and a specificity that ranges from 89 to 91%, which is quite good, with a mean sensitivity of 88% and a mean specificity of 90% in terms of diagnosing in or out intellectual disability. So I'm done. Again, in summary, I think this provides us with, we're very excited, as you can tell from me, I'm jumping up and down here. We're very excited to have our tool come out now because it's specifically developed to meet our conceptualization of adaptive behavior, of conceptual, adaptive, social, and practical skills. We think it would be an excellent tool for diagnostic, but also a good tool for tracking intervention outcomes for people with trisomy 21, Fragile X, and other developmental disabilities. The administration time is, and here we always lie a little bit, is probably about 30 minutes, depending on how proficient the interviewer and how chatty the respondents are. But it's certainly shorter than some of our longer available instruments. We think it's most robust around this cutoff area, where we make our decisions. And thanks to my colleague, Professor Verdugo, it's currently available in Spanish. And I'm working with Yannick Courbois, Université de Lille, on developing a French translation, which we hope will be out soon. Merci beaucoup.